Anthony Brown. I'm the CEO of Health Consumers New South Wales, and I'd really like to welcome you all here today. I'd ask people to please keep your microphone on mute, and if you have any questions or comments, to please use the chat box. I'd also like to acknowledge that this meeting today is happening across Australia, and we even have some international guests joining us, and acknowledging it's happening on the traditional lands of many Aboriginal communities and nations, and we pay our respects to all Aboriginal people who may be joining us and to Aboriginal elders past, present and emerging. And I'd invite people, if you'd like to introduce yourself, to use the chat box, and in the chat box you can also let us know the traditional lands that you're joining us from today. I'm on Gadigal land myself, so that would be lovely to know. Just before we start, I'd like to let everybody know about this work and how it came about. In 2017, the Every Age Counts campaign, which is a campaign challenging ageism, and a campaign I'd really encourage everybody to have a look at, launched research that showed that healthcare was the place where older people reported that they were second most likely to experience ageism. Aged care was number one and the workplace was number three. And this really inspired us here at Health Consumers New South Wales and our friends and partners at Older Women's Network New South Wales to start to look at that, because it confirmed anecdotal reports that we'd heard from our members about their experiences of healthcare. So in 2019, we launched a survey to ask people to share with us their experiences. And the aim was that we were going to have a workshop last year to talk about that, but COVID scuttled those plans that did so many things. But we were able to keep the survey running longer and hold a series of interviews with people who told us about their experiences. And from that, we developed a report, What Can You Expect at Your Age, that I hope you've all had a chance to see. And we'll talk about the findings of that report today. And I'll also put a link in the chat box when I finish talking now. So we're very grateful, and I'd really like to acknowledge the work of not just my colleagues here at Health Consumers New South Wales, but the partnership we formed with the Older Women's Network, and two remarkable young women, Akriti Chetri and Natalie Kanawati. Both Akriti and Natalie have been working really hard on this report. Akriti started as a student placement at Health Consumers New South Wales and has become a volunteer with us, so we really value that connection. And Natalie started this project as a student placement with the Older Women's Network. These two young women did a remarkable job bringing the stories and experiences of older people together. And I know we're focusing on older people in this discussion today, but I feel the future is really in safe hands when we have such remarkable young people involved in projects like this and passionate about justice and projects like this. So thank you, Akriti and Natalie. So as I said before, I'd really invite people to make comments and suggestions in the chat room. We'll be following the chat room, and Akriti and Natalie are standing by. Hopefully we can answer some of your questions in the chat, but they're also standing by and they'll pose those questions to our moderator as we move into the panel discussion. The copies of the report that I mentioned are available on both the Older Women's Network and Health Consumers New South Wales website, and I'll be putting links to both of those websites in the chat as we move through the discussions today. So I'd like to introduce you now to somebody who's also played a very special role in this process, and that's Dr. Tracy McDonald. Tracy's dedicated her professional life to ensuring that the rights of older people are respected and that services contribute to their quality of life. and she was made a member of the Order of Australia for her work here and internationally. So I know it's very belated congratulations, but congratulations, Tracy. And following 15 years as Professor of Ageing with the ACU, Tracy now works as a consultant clinical gerontologist and associate editor with the International Council of Nurses. And she's also a member of the New South Wales Ministerial Advisory Committee on Ageing, where she advises on policies and issues affecting older people in New South Wales. And Tracy's work with us really helped shape the wonderful findings from what people told us into the fantastic report that we have today. So that's enough of me now. I'm very pleased to hand over to Tracy and invite Tracy to turn her camera on and to lead the rest of the discussion. So over to you, Tracy. Thank you.
Thank you very much, Anthony, and welcome everybody, and thank you for attending. The point of inviting me to do this is really I'm just piggybacking on the great work of Natalie and Akriti, and I'm trying to direct some attention onto some of the issues that are raised in that report with our expert panelists. But before I actually bring the expert panelists on, I'd like to say a few words about the actual topic and about the question that's raised here. Like, what can you expect at your age? It seems to be a very rude thing to say, but what if we chose to treat that as a legitimate question? Just ignoring the ageism in it for a second, the question asks about realistic expectations held by people who have survived and even thrived over many decades because of their wise decisions and good choices. Long life is an achievement that rarely happens because of luck. After 7, 8 or 9 decades of life, it's worthwhile considering what we can legitimately expect in terms of health, fitness and well-being, and help from other people. Normal aging is just that. It is normal. Therefore, adapting to gradual change in function over a long life is just part of living. And many fields of science and technology have developed around assisting people to delay or overcome a lot of the limitations that happen in normal aging. And that allows us to stay engaged and enjoy those extra years of life. The quality of life we might experience in older age often depends on how well we manage aging processes and prevent chronic conditions from developing and getting worse. We try to manage these changes with the help of health professionals, nurses, physios, doctors, dietitians, OTs, dentists, pharmacists, social workers. The list is endless. A lot of very bright people with very good skills are there to try and help us manage this. As lifelong taxpayers and service clients, we are entitled to expect proficiency and ethical decisions from healthcare system administrators at all levels. Failure by any of these staff in the diligent performance of their paid work places vulnerable clients at risk of life quality loss and, of course, further misery and even premature death. It is also reasonable for us to have expectations around access to essential services, to be included socially and to remain connected to our communities and families. In a civilized society like ours, older people should expect and can expect to be acknowledged, considered and respected for our decades of personal, professional and financial contribution to the society that everybody now enjoys. And also for our life experience in the senior roles that we fill in our families and more broadly. And that is what you should be able to expect at your age. Now, having had my little rant, let's have a look at what actually may be happening on that front in New South Wales, which is the most densely populated state in Australia. In the recent investigation, the report provides a snapshot of ageism experiences described by quite a capable group of people who were able to access the survey. The results strongly indicate that there are problems that need to be addressed and need further investigation. So without further ado, I'll introduce our wonderful panel. We have 3 people who have involved themselves in the types of issues that the report raises. Each of our experts has championed best practice and efforts to improve the life quality experienced by older people. Valerie Sharkey, who is currently a dementia advocate, draws on her many years as a physiotherapist, specialising in the areas of dementia and stroke, and she's an acupuncturist. Val's efforts continue to be focused on early identification of any functional problems and preventing further deterioration by saving what we can. Dimity Pond is a general practitioner in Barara and also a professor of general medicine at the University of Newcastle. Welcome, Dimity. As well as treating patients from across the lifespan, Dimity is well known for her advocacy for aged care and for people living with dementia. Vasi Nagatharan is a consultant geriatrician with the Concord Hospital Aging and Alzheimer's Institute. He's also Professor of Geriatric Medicine at the Centre for Education and Research in Aging at Sydney University. Vasi acknowledges that medical treatment for older people is complex, and sometimes it might be better for them not to have treatment than to undergo procedures that could add to their misery. Thank you all for volunteering to be part of the panel and sharing your thoughts on the issues that we're going to raise. So let's get right into some of the issues. What I've done is I've gone through the report and I've looked at some of them, the themes that emerged from that report. And I'm putting some questions around each of those themes. So for each theme, each of the three of you will have a chance to share your view with us. So firstly, ageism is not an uncommon experience of older people when accessing healthcare. Many people believe that their doctors either don't take what they say seriously or that they ignore what the patients say. So Valerie, what do you think is the underlying reason that some older people don't feel they're being heard by their doctors, and how do you think this can be fixed?
It's down to doctors actually willing to listen and not just go on what they're seeing. With a lot of the experts taking only 5% of self-reporting into their final diagnosis of what's going on, they often get it wrong, because people can have enough adrenaline and present well on the day, and if they're not well, they'll cancel that appointment and come when they are well. So they're being seen at their best, and that's not necessarily the true position. Then we go on to the inbuilt prejudice that's there against women with silver hair and smiley faces and fat and who are not believed. There's an inbuilt radar. My daughter said, "Oh, Mum, you're just over the top." And 2 weeks later, she rang me and apologised. She said, "I was in line at a delicatessen. A woman a similar age to you was in front of me, and the person looked past her and asked what my order was." I said, "We become invisible once we get over the late 50s, early 60s. And the nicer we are, the less we're taken notice of."
So you're suggesting that perhaps we don't assert or we don't communicate really clearly to overcome that.
Already 40 odd years ago, because my specialty was complex pain. And so that like dementia is no respect of persons. I would already be telling people who'd already spent their $400 and been gone in 15 minutes and not been heard. I said, if you go back again, you will stamp your foot. You will throw the biggest hissy fit. You will not leave that room until your list of questions is actually heard and answered in a language that you actually understand and get. And preferably you're taping what's being said, or you have somebody with you, or you ask for the answers to be written out so that you can access them. Because often if it's bad news, you're in such a tiz that you can't hear everything that's being said. And the specialist thinks that they've covered all the bases, and it just doesn't get through to grassroots, to best practice. And yeah.
Well, thank you, Val. Dimity, you have a reputation for taking time to get to know your patients and encouraging them to share in the decisions that affect them. So are you aware of practitioners who are less likely to do what you do and listen to patients?
Well, yes, Tracy, of course, and I've experienced it myself. And I guess practitioners are like the rest of the community, and there's a wide spread of interests and skills, communication skills. So there's no doubt that there's a widespread of practitioners who don't listen. And that's actually made worse by the funding system that rewards people for chunks of time, rewards the practitioner for spending chunks of time with a person. And if they spend more time, they don't get paid anymore. And in fact, they may lose money because then they see fewer people. So that is really a perverse incentive.
Have you any ideas about what can be done about that? Do you think it's the way the funding system is set up, or do you think it's a cultural thing?
I think it's both, actually. So the funding, do you mean the funding system is a cultural thing?
Well, they're interlinked, of course, but you know, the fact is that a lot of people have an attitude towards older people where they don't really listen. They sort of process them and what they're saying, and then they move on. But can we do anything about this? Is there anything we can do, do you think?
Yes. Well, I really like Val's suggestion of having someone with you as an older person. Perhaps recording, you can ask permission to record a consult, and you can listen to it, and then you can come back and say, you said this, what did that mean? Why not? You can do a bit of homework before you go. If you've been referred to a specialist, ask, is this someone who would listen to me as an older person? I tend to tell my patients, well, you can go to that doctor and they're very good. They know all their medicine, but they won't talk to you. And there are lots of very smart people like that in the medical profession. So, you know, as long as you understand that, you'll get good advice. So all of that, but I actually think there needs to be a cultural shift in education for medical professionals. And
we'll get on to that a bit later in another question that I've got for you. Vasi, now you've said that treating older people with multiple health problems is hard. Can you just tell us what's so difficult about finding an accurate diagnosis for people when they're in late age, and then linking that to an effective and appropriate treatment?
Many people have multiple medical problems. And the challenge is to work out is what should be treated and investigated, which will actually improve the quality of life of the person, and what can't be fixed, what should be left alone, and sometimes having really complicated, detailed discussions about the pros and cons of treating versus not treating, investigating versus not investigating, because sometimes too much medicine can be harmful. So in fact, the challenge, what's difficult is that sometimes older people suffer ageism because they don't get enough medicine, and sometimes they suffer ageism because they've got too much medicine, which ends up being harmful. So if I was to give, perhaps I'll give one example of each. So an example of too little medicine is, I do get rung up about someone's come to the emergency department and they're unable to walk and function at home. And sort of the presentation starts with, they can't manage at home. They've got acopia, which is a terrible thing to say. But the reason they can't manage at home is they've got medical problems. And the challenge is not to work out, the problem is not that they can't manage at home. The problem is that they've got medical problems that have come on urgently that need to be fixed. And if a younger person somehow fell over and broke both their legs and was living at home, nobody's going to say they've come into hospital because they can't manage. They'd say they've come into hospital because they've got a medical problem of 2 broken legs. I'm choosing a ludicrous example, but that sort of sums up the problem. Now, the problem of too much medicine is that people sometimes end up going to a merry-go-round of specialists and other people. And sometimes someone needs to say, well, actually, you know what? This is what we can realistically fix. This is what we can't. And the problem with that is, and that comes out in the report, I think, is that that can be seen as ageist. oh, because I'm of a certain age, you're saying I shouldn't have these done, or I shouldn't go and see these, or I should cut down my medicines. But it's not that. It's actually that too much, this is potentially harmful. And the key then, of course, and I think this comes up well in the report, is communication is the key. Even that can be a challenge in older people, because the agendas of my patients may be different from the agendas of their children. Well-meaning children, but their priorities are different, right? And there's great work that you may be aware of that actually talks about the difference in priorities of older people versus their loved ones, right? And that can be a challenge.
That's true. Thank you. Thank you. That's very good. We'll move on to another theme. And the report builds on a number of previous reports and articles that claim that in Australia, and of course elsewhere, there is a prejudicial bias against older people, patients trying to access healthcare, the healthcare sector, where younger patients are prioritised. Now, Vazi, if you could answer this question, have you found that there is pressure on older patients in hospitals to be discharged to residential aged care service or elsewhere, rather than to be admitted for rehab services in the hospital? Have you seen that? And
actually, not necessarily. No, actually, there actually isn't necessary pressure to discharge people to residential care, and certainly in the rural areas, people can wait a long time to get a residential care bed. So I guess if your goal is to get people out of hospital, saying that they need to go to residential care doesn't necessarily get them out of hospital. But there is pressure. So I'd say more generically, right? There is pressure for older people not to come to hospital and to be discharged in general. And so I feel strongly about this. There should not be models of care and policy where the primary objective is hospital avoidance as the primary objective, right? Or to keep people from nursing homes out of hospital, to keep people out of ICU. And why that's ageist is if I swap older people for, well, I can say this, dark skin. So if you said the primary objective of our policy is to keep dark-skinned people out of hospital, out of ICUs, not into hospital, that's clearly racist. Now, I want to clarify, because people might think, well, he's being ridiculous here. It is about the right treatment in the right place. So it is reasonable to work on plans to provide, for healthy people to have things to maintain their health so they don't end up in hospital, for frail people to be managed out of hospital through primary care in particular. We've developed great services now in some areas to provide good health care for people into residential care. But the prime objective of all of those things is the right treatment at the right place. The primary objective should not be stated as to keep people out of hospital, because I think that's ageist. And I think bad things happen when your starting point is, let's keep a particular group of people out of hospital. And in fact, what was reassuring is that during the early days of COVID, when people were talking about we might struggle with intensive care beds, and there was whispers about whether there should be an age cutoff. The people in the real know, that is at a high level policy level, and the ethics people said, actually, you can't have an age cutoff.
No.
And in fact, that was never going to happen. And so I was very reassured to hear that at the highest level, that was never going to happen. People said you can make decisions on whether it's likely to work, because we do that all the time, whether intensive care is likely to be successful, whether it's going to put people through hell for nothing. But that's not based on age, that's based on medical decisions and what people want and their wishes and so on, rather than age. And so it was reassuring to hear that that was never really going to happen. Those people who mattered were quite clear, you can't be using age as a cutoff.
That's right. Thanks, Fazi. Dimity, have you found any similar problems? And could you also, because you actually manage a lot of people who are dealing with multiple comorbidities and problems and getting through the day, what role does age play in healing and recovering from either trauma or injury in the primary care sector?
So, well, we all accumulate conditions as we get older, more likely to have high blood pressure at certain ages. Actually, that tends to go down again later. Cholesterol, heart problems, sugar. So lots of, a bit of cognitive impairment. So lots and lots of things happen to us as we get older, and that's just the physical body. And of course, as well as that, we accumulate life stresses. So, I'm just looking out the window from the study here, and I can see a beautiful tree turning autumn colours, and it's beautiful. And there are always beautiful things, but there are also stresses, aren't there? And we do accumulate those as time goes by. So I think some of the psychiatrists have talked about age as a time where you come to an acceptance of things more, and there's a wisdom with getting older, and being able to let things go a little bit. And I think that's wonderful. But there is also the potential, particularly if you've had a very hard time. For example, my father was in a prisoner of war camp in World War II. And when he had to go to nursing home, the rows of beds made him think he was back in the camp. So you can get triggered as you get older by situations that remind you of things that when you were younger. Uncommon is that. Yeah.
And Valerie, what are your thoughts on some of the underlying assumptions about older people that can cause them to miss out on getting into hospital or accessing treatments? Is there a problem with people not knowing how to work the system?
Oh, not knowing how to work the system is huge. The number of times I actually help people to work through how to apply for packages and go through, and I say, look, just ask them, what's going to be in my pocket? The glossier the brochure, the more likely you're best to stay away from it. That's my other little thing. But in terms of, I wear a different hat today as well, because my daughter works in ED, and again and again, what she would really, really wish, I can't see it come up in our subject, so I'm bringing it up now. What she'd really see is everybody over 18 would fill out how they wish to be treated if they have a terminal disease, because it would save us millions of dollars, and it would save us a lot of unnecessarily intrusive treatments for people in certain areas. It's because she's been in the community for nearly 20 years. And I know of 3 cases personally where they went in and they came in with an acute affection, something acute, but they were ready for hospice care. And the ED doctor was all set to put in the cannulas and made the IV antibiotics and send them off to the regional hospital and all of that rah-de-rah and rah again, which had been previously done the last 5 times. But no, she said, no, not this time. You need to look at their paperwork. You need to look at you need to ask them, what do they wish now? And to have the advocate with them to be talking about it. Because so many times, doctors often think it's a failure when somebody dies. We're all born to die. We need to talk about quality of life over length of days. And that's best aging, is quality of life. So now I've forgotten what your original question was, but that was really important to be saying that if you haven't got your end of life things in process, just do it. I normally wear a do not resuscitate bracelet because my family history is heart disease. And you resuscitate me, I will sue you, and I'll be the first court case to make a point that you've got to obey a legal document.
Okay, thank you, Val. We'll move on to another question about about policy and regulation, I think. Age is often as a factor in determining eligibility for services and benefits and for support. And there's also a factor when you look at the number of university places for health practitioners, when people say that, well, we would have more staff, but there's a shortage of nurses, or there's a shortage of doctors, a shortage of specialists. So the adequacy of the university numbers in actually producing enough appropriately qualified people in Australia to meet Australian demand is something that we also need to consider in terms of a kind of a lack of preparation for ageing populations. So I would like to ask, I think, Dimity, if we think about family medicine as the mainstay of general practice in the primary care sector, are we getting enough people choosing to be general practitioners compared with other specialty areas of practice? And what is it about being a family GP that attracts our best, that could attract our best and brightest?
Well, I love general practice, and I think it's full of variety, and I don't understand people who want to just look at one small area of the body and not the whole person, but that's me. So the answer is that no. In fact, the number of applicants for general practice training has been reducing, and although there's a certain number of places for general practice training after university, those places have not been filled the last few years. So that's an issue. Is that so?
Well, it's certainly an issue when you think about the ageing population, and that there is going to have to be a dramatic increase in primary care options for people who don't want to be admitted to institutions and who could have their conditions managed without going to hospital. So it actually is looking to be shaping up to be a serious issue, Dimity.
So part of the problem is that we are supposed to see people in under 20 minutes. And if we charge too many longer consultations, even under Medicare, we may be reviewed, why are you spending so long with people? What's wrong with you? Can't you just push them through, We'd love to send them to the geriatrician, Vazi, but there's not enough of you. And so, and it's actually, there's been 15% more people over 65 every year for the last decade in our population. And as we said before, people have lots of chronic medical conditions, but actually we've also got all this life trauma and burden that needs to be unpacked and supported as well. And it's a time of transition. You become more dependent as you get older. I hate becoming more dependent. I want to keep my independence as long as possible, but the time will come when I'll need help. But that in itself is difficult. And COVID, of course, has made things incredibly difficult for older people. Isolated them and kept them away from their families. So we have a lot of kind of psychosocial support to provide. And the 20-minute time blocks don't work for that. And so the students feed back to us that it's hard. It's really hard being a GP, and they'd rather specialise in the left big toe or something, and they can get on top of that area of the body. I'm being silly, ridiculous, but they can get to know everything they need to know about that. Whereas there are so many imponderables. And then, of course, they've also carrying huge HECS debts now, 40,000 a year for studying medicine, and for 5 years, it's a lot to pay off. And when you get paid $38.75 for 20 minutes with an older person, and 40% of that has to go into practice, you end up with $25. They kind of go, it's going to take me a long time to pay off my education expenses.
Just as a rough calculation, so they'd probably have to see something like 28 patients a day in order to make baseline.
Yeah, I haven't done that calculation, but you might be right. And so, and that's, you know, they've got mortgages and things, so, and families to support.
Okay.
Kids in private school. So.
Vazi, geriatrics is a highly specialised area, and is it popular? I mean, Dimity was saying that there are not many geriatricians around. Do students choose it?
Yeah, do you know, just the last meeting, you know, so our membership, the Australian Society of Geriatric Medicine, was about 300 in 2000, year 2000. It's now about 1,200. We're probably training more, we are training more geriatricians than ever. So I think there'll be a good supply of geriatricians, but it's the same issue for all of medicine in Australia, which is that there's a concentration of doctors in metro and large regional areas. And then when you know, as you move out from those areas, there's a real shortage, right? There's a shortage of everyone, from general practitioners to general specialists like geriatricians to subspecialists. So that's, you know, that's always the difficulty when you talk about medical workforce in Australia. It's so unevenly distributed.
Have you any ideas about how that could be challenged? For instance, if you made licenses to practice regionally based?
That hasn't really...
I'm only kidding with that one.
Yeah. You know, whatever's been tried hasn't really worked, right? So, you know,
that's right. Yeah.
You know, the idea of medical schools rurally hasn't quite worked because people who grew up in the country and study in the country then think, you know what, I'd like to go and have a taste of life in the city. Or it depends who their lifelong partner is and so on. So
that's right.
I have a lot of experience in working in a reasonably large regionally, and I grew up in one for part of my life. And I haven't got the answer to that, but I think that's when you talk about workforce in Australia, medical workforce, that's the difficult nut to crack.
It is. All right then. Well, we'll move on to another theme.
No. Can I just add a
sorry, Val.
That,
sorry, I forgot you.
No, that's fine because, well, it's not my expertise as such. But functional integrated medicine should be the new 21st century approach, and it should be not on the fringe. It should be front and central, because its aim, it's expensive to start with in a sense, but it's not, because it finds, from my personal experience, the doctor who examined me did not leave one stone unturned, and he found about 8 issues and 6 I had no idea about. So since 2018 we have been garnering each of those issues, and I am the most healthiest I have been in my 69 years. And so functional integrated medicine is it should become the specialty. This young man in the 90s who I worked with, he's after 3 years of being so frustrated, he just said, I am so tired of being down the bottom of the cliff with the rest of the Band-Aid mob fixing the problem, fixing the local thing. I am going 100 mile back, and I'm committing my life to keeping people well. And that is what he's doing. And he's made such a change in our local region that I think that should be cloned and amplified and put as high priority, that you'd look at the whole somebody's looking at the whole person in a process and being remunerated for it, because it's going to save so much money in the longer term.
Thank you, Val. Thank you. The idea of people who can afford better care, get better care, is growing in popularity, and we're not as bad as what's happened in the USA yet, but we know that people who are well off and educated and socially connected actually do receive more care and better care than other people who are poorer and disadvantaged and may not know how to access it. Dimity, what's your impression of the quality of healthcare services given to people who are on bulk billing or who request bulk billing and those who have private health insurance? And does the gap payment deter patients from accessing their GP when they should?
So private health insurance doesn't cover the gap that a GP pays, might charge, the gap between the $38.75 and whatever it is that they charge for a standard consultation. You can't use your private health insurance to cover that gap, unfortunately. So, either the person pays privately and pays the gap, or else they see the doctor and the doctor receives less money for that service. So how do doctors deal with that? Well, they do probably tend to see people a bit more quickly when they're getting paid less. So that's life, unless you're sort of like, you know, I'm an academic and I'm getting paid an academic salary, so I'm not relying on my practice income for money. So for all my money. So then I can afford to spend more time, and it's interesting. And actually, despite all that, well over 50% of people in Australia are just charged the Medicare rebate. So, despite that issue, you certainly can see people under Medicare. And if they're in a fortunate position like me, or a bit older and not relying, you know, having to pay the mortgage off anymore, then you may well get that longer time as well.
Thank you. And Vazi, have you found that money talks in terms of access or standard of care from geriatrician specialists?
I guess the majority of geriatricians work in the public system, and there is a developing good private system of geriatric medicine as well. I guess for the acute care, we rely on the public system because, you know, the private system, only a few private hospitals have emergency departments. And so I think that works well. I'd agree with Dimity that if you don't have private insurance, there might be delays for elective procedures and elective things. And sometimes people have to shop around to find, you know, a specialist that doesn't charge such a big gap. I'm sure GPs, that's a challenge for them to navigate with their patients. Sometimes having private insurance can be a disadvantage because people really do end up having too much medicine, which then ends up being harmful. You know, we're such a wealthy country with a basically good health system. I'm reluctant to be too critical, having gone to countries which don't have as much money as we do. But I think there's still a wider issue, which is that, which you sort of hinted at, in terms of community services and accessing things. If you haven't got good advocates, if English isn't your first language, if you haven't got money, it can be difficult to access the help you need at home and navigate the system. And that's where, you know, money, your ability in English, your level of education, your having advocates all matter, you know. The biggest group of homelessness change is in older women.
In older women, yeah.
And that then impacts on health.
Of course. And Val, you mentioned before that the difficulty in being assessed properly in a doctor's room on the day when a lot of effort's gone into getting you nice and tidy and all spruced up and all geared up mentally for this event. Do you think money is actually an issue for people who should be going to see their GP more often, and they're hesitating because of the gap payment? Or do they, or as Dimity says, do they actually get the bulk billing if they're elderly?
It's not, no. The GP I'm choosing to go to at the moment, I pay a gap because I have followed her, because she listened to me and has helped me considerably. Otherwise, I'd be bulk billing. I would prioritise someone, have continuity over the money, but then I have a little bit of slack. I don't have a lot, but my husband's a vet with TPI, so we have a third pension in the sense that others don't have. But being country folk, we're really, really frugal. But I know of so many people who've put off going to see the doctor, or they've presented at an emergency for something that should have been a GP. I just feel that there should be a GP practice alongside most of the ED's departments, and it would save, it would release the people in ED for the actual emergencies, and not for the person with the cough or the cold or the sore tummy who can't pay or can't get in to their GP for that issue. I mean, my other I've got a family member down in Newcastle where they have the super clinic, and she took her son with a boil the other afternoon to the super clinic because it progressed quickly in the day and she couldn't get into a GP for 3 days. So that would be a very, very good value, extra value use of money. And speaking of value use of money, if you increase the capacity of the specialist nurse in the GP clinics, people say again and again, how can we get the information to a GP? I said, they're too busy. You've got to get it to the specialist nurse, or even not even the practice manager, because it often gets shelved, but to the specialist nurse to have it to have it implemented. And so even in aged care homes, if you have your specialist nurse to address what needs to go to the hospital and what can be dealt with here with the service we've got involved, we would save so much money and so much time and so much trauma.
Yes, I agree with you, Val. Now, we'll move on to another theme. There's a perceived deterioration of professionalism within health practitioner ranks when they speak to patients and badly, and they appear not to respond to patients and the family concerns. And some of the stories in the report highlight some of those really quite unfortunate communication exchanges that have left patients walking away wondering whether they can actually trust that person or not. And it comes down sometimes even to uncivil behaviour by some, and that reflects poorly on all other practitioners who will then have to rebuild trust and rebuild reputations because of a few. So this whole thing about bad experiences with health services, Val, are doctors in danger of being stereotyped as rude or incompetent or untrustworthy when this happens? Or are people smart enough to know that, you know, if they have one bad experience or even 2 or 3 bad experiences, it doesn't mean that all doctors are like that?
You are correct, because I've had the 3 or 4 bad experiences, and I refer to a Mr. with an M, small r, for one who's actually worthy, and the others the MRR, and on this sort of capital. And so I was foolish enough to think that when I actually had major health issues and went to be listened to, that I would have had almost the peer-to-peer respect that I'd had some years earlier when I was having the ear of 30 GPs and a dozen specialists discussing pain and best outcomes. And that didn't happen. When I had a paradoxical great reaction to a common dementia drug, by the time I was asked the fourth time, what have you done since I've last seen you? Then it's an attack on my character. And he met the pit bull terrier with lipstick. Sometimes I just say, research as much as you can, ask around, find out the pub talk, find out the ones who actually listen and do, and who are worth the money to go to. Because Yeah.
Val, can I ask you, why is it important for patients to have confidence in their doctors? What do you think is so important about that?
Well, you've got to have trust. Even now, I was given a report on Tuesday that I'm really, really struggling with, because I'm having to basically now trust a third psychiatrist when I've had bad experiences with two, and I feel that the diagnosis is wrong. But because on the day, yes, I presented with the symptoms that he came up with, but that's not my full story. So now I'm having to address what the go is. And so I'm having to then take my guardians with me to further discussions to work out what's going to be the best for me, because it's going to be a radical change to what's keeping me what I think is really, really well at the moment. So if you don't have trust, there's not much in life.
Well, it does undermine your confidence in the treatment. Yeah, absolutely. Dimity, do you think there's a different level of interaction needed when older patients are not able to articulate their concerns or what they want? Or do you rely on the family's version? How do you handle this?
It is sometimes really good to have family there, and to get a bit of a general view. So I like, and even I've used a bit of telehealth with the family, perhaps beaming in from somewhere, and the person sitting with me, so we can get a bit of an understanding of what they're concerned, the family is concerned about, as well as the person, and they may be sort of different, you know. So so there's no doubt about that. That is another thing that takes time, but it's really worthwhile, I think, getting everyone on the same page. So, and I think another thing that really helps in difficult situations is to focus on the goals of care. Okay. For example, for older people, to maintain their independence is really important. And that might be their goal. And the family might actually have a goal of keeping them safe. But that might mean chuffing them off to nursing home. In their view, that'll keep them safe. In fact, they can still fall. But anyway, so we need to remember the dignity of risk, of allowing people a degree of risk that's consistent with their goal of maintaining their independence, and have that discussion with the family about how much. But there's probably a limit. You can't just let someone, be on the floor for 48 hours. That's terrible. So you have to have that discussion really with the family, and that's something my geriatrician colleagues have taught me a little bit over the years. Should probably happen more, and focus on the goals gets everyone on the same page too. So
yeah, and if they're all agreed goals, but not goals pushed on people. Yeah, okay. Vazzy, talking about, a lot of this is about communication, and a lot about it is professional standards and ethics and all of that sort of thing. Do you think that that's actually given a sufficient emphasis in undergraduate curricula for medicine?
Much more than it used to be, right? Much more than it used to be. I think people have short memories. That there are doctors and doctors in particular weren't very good at it. In general, they're taught much more about communication. It's valued. When they come to selecting people into training schemes, they value communication much more than they used to. So, in general, I'm pretty impressed with the young doctors I work with coming through. And I have a theory that they've actually spent, this generation of people, say aged in their 20s, are more likely to have spent quality time with their grandparents, right? Because people are living longer, right? So they've actually probably had more exposure to quality time with older people than previous generations, simply because people are living longer, right? So yeah, you're right. Communication is absolutely important, and there's much more emphasis put on it now, right? And in a way, the good thing with an oversupply of doctors going for specialist positions, and general practice tends to fluctuate, is that gives you a chance to weed out the people who are not good communicators and, you know, not particularly good people, really, because now you've got an oversupply. You can choose the good people. You know, that is one of the good things about an oversupply, right? That you can actually, and word gets around, you know.
Oh, word does get around.
Word gets around. And, you know, I always tell the junior doctors, you know, you might be, you know, don't think you can get away with being nice to people above you in the totem pole and then be awful to the people below, because you don't know the connections. You don't know that I've been friends with a num on the ward for the last 20 years. You know, we've grown up together. So if you're awful to him or her, they'll have a quiet word with me, right? They won't say it to your face. So I feel reasonably optimistic in general, right? That communication will continue to improve because there's a real emphasis on it now.
Yeah, look, well said, well said. Now, moving on, health service administrators. Quite often they are not spoken about in these sorts of issues, papers, but in fact, when you think about it, it is the administrators who decide staffing ratios, skill mix, admission criteria, job design, absent staff replacement, whether you're going to replace somebody on sick leave or not, work rosters for health practitioners. And all of this creates work stress on people if it's not done well. They also decide on the quality and availability of equipment and services and how the environment's going to run. And these decisions, I think, they need to be held accountable for, because it can actually result, if done badly, it can result in miscare, de-skilling of practitioners who don't get to actually practice what they are supposed to be doing, as well as risking hospital-acquired infections and traumas such as fractures and treatment mistakes. So I think it can't all be down to the clinicians. It can't all be down to the patients. The other very big group of people in this mix are the people who make those administrative decisions. So they, therefore, share the responsibility for any frailty or deconditioning of older patients who get little help with walking or toileting or feeding because of low staffing, or inadequately skilled staff, or poorly designed environment. So I'd like you to think about that for a minute. And Val, I'd like to ask you first, the family and carers of older people admitted to institutional care in hospital or aged care continue to do a lot of the care and treatment that that person needs to maintain function and to enjoy a quality of life. So do you think that the family members who voluntarily provide daily care and therapy for their family members or friends in hospital are taken for granted by administrators? And do you think those administrators take the presence of that voluntary labour into consideration when they put the rosters together?
Well, COVID showed up what happened when the family and the volunteers weren't allowed into that care. The abuse by lack of care and the number of people whose conditions deteriorated markedly through lack of stimulation and loss of weight, and on the other abuses. I mean, I personally witnessed it when I went back to visit a dear friend. I hardly recognised her because there wasn't the extra time given. The chronic understaffing, it happened back in 2007 when the current government blurred the roles of the people from AINs to cleaners, and now we had personal care workers, and the bottom line of their training is pathetic in the terms of
so you're talking about aged care.
Yeah.
What about hospital?
In hospital, yeah, I mean, if any of my family members go to hospital, I'm there as sitting in the back as their advocate, making sure that a drip doesn't run out, making sure that bedpans are brought. You know, I understand the special needs of my family. It's easier to keep the black dog out of their head than out and away out of the room. And so, yes, with COVID, visitors and family aren't really welcomed at the moment. And, you know, there's some areas that still say, well, you can be here for an hour or two, but you know, the body language is such, we don't really want you because of the risk of infection as such. It's starting to ease a little bit in the last month, but no, we're volunteers are underappreciated, taken for granted, and then staffing ratios. Oh my goodness, if you want to see me start to get stirred up about that, because I see the people who are leaving, the best registered nurses who are leaving en masse because they're burnt out. They're not listened to, they're not appreciated. My daughter in a 9-bed ED ward is working on her own at night with a GP that's got to work through the whole hospital. It's only 4 hours extra funding that they can't find to have a second registered nurse on that ward each night. She says, Mum, it's by the skin and the teeth and grace of God, we're not on the front page. And she's been trying for 3.5 years to get that listened to and changed. And I don't know who it is above that not getting it. So who looks over the administrators? Who's making sure that they're doing the right decisions and not doing the boys' club or the girls' club, whoever's whatever? So the whole system needs to be looked at afresh.
It needs to be transparent, and the decision making and the resource allocation needs to be transparent. Absolutely. Yeah. Thank you, Val. Vasi, have you actually been aware of any impact of low staffing or different staffing levels in hospitals where you practice, and has it affected your older patients?
It's a similar answer to the previous question. It's the maldistribution, right? I work, you know, in the city hospital I work in. We're relatively well staffed. You know, our wards have their own physios and allied health. I then go rurally to a base hospital, and there's one physio for the whole base hospital. So that's the challenge. And look, the bigger picture question. Ultimately, the administrators do have to balance books, right? I don't hear too many politicians going to us and saying, I'm going to raise taxes significantly so I can provide better healthcare. No one's, I don't think you're going to win many votes if it's your own hip pocket. And that fundamentally is part of the issue, right? You pay what you get what you pay for. So that's a society decision if we're willing to pay more to get more, and whether we're going to pay more for older people. So that's a very fundamental question that will then depend on your political philosophy and other things. But I think the simple question is there's a big discrepancy, right? From Val's example to, you know, a well-resourced metro hospital, where, you know, there's an oversupply of nurses, right, to get into sought after positions or wards, and then there are places that can't get anyone, right?
That's right. And Dimity, do you find that the two systems work well together? I mean, as a GP, do you have any input into the continuity of care going for patients that you refer into hospitals and then come back? Does that part of the system work for you, for older people that go in?
The transitions of care don't work very well, I don't think. And some of that is, so from the GP to the hospital, if we send people from our rooms, that's fine. But if they're transferred at night from residential aged care, where there's sometimes not a registered nurse on, and, you know, that it's maybe seen as an emergency, then, and we don't necessarily even get told, then that's the communication isn't ideal in those circumstances. Coming back from the hospital, I would say it's improving in our area, but there could be more improvement. The discharge summary, which is a summary of what happened in hospital, tends to be written by the most junior medical person on the team. And so there is still learning. And sometimes it's not the person that looked after that patient because the terms rotate. And so there's a new person who's inherited 50 discharge summaries from the previous one, and they're just trying to work it out from the notes, and that's very difficult. And if it's a person with complex needs, an older person, and lots of different care decisions, that really does need some more work, I think.
So continuity of care is really important for older patients. Really important. It's important for everybody, but for older patients particularly.
Yeah. And we're not getting that. We're trying to cobble together from what the person can recollect and what we can see written down, and maybe some input from the family, what actually happened, so that's tricky.
That is tricky. That is tricky. Okay, so I think I've asked everybody on that question. I'm losing my track here. I'm getting involved in the conversation rather than moderating, but I'll get my act together. Now, some doctors in primary care refer complex conditions to hospital emergency departments. We know that. Hospital practitioners have been described as a failure of primary care when this happens, that conditions that should be or could be managed in the community being sent through to the emergency departments takes up the emergency department and overloads them. And it has been described as a poor reflection on the medical competence of GPs who do this. So Val, you've actually said in your approaches to healthy aging, you've got to find it early and you've got to save what you can, etc. But as the trend away from institutional care and aged care gathers pace, what community-based health services do you think need to be developed to support a rapidly aging population? At the moment, we're heavily reliant on general practice to be the hub of community care. Do you see any other options that need to be developed to support older people?
Very, very much so. There's got to be a lot more inclusion. There's got to be a lot more listening to as such. I've alluded to it before about more functionally integrated medicine approach, where you're looking at the holistic person. There's got to be, prevention is way, way better than trying to fix a complex problem. Looking at the increasing the capacity of the primary care nurse, even increasing the capacity of the pharmacist to be a referral person, to be used more, because they have access to the pamphlets and the leaflets and the things. So many GPs are just too busy to give out that extra information. But even, well, with COVID now, you can't have your stand of leaflets for interested people to pick up and take. But to even just have somebody to translate for them in terms of, if this is your issue, can you please talk to that person? In terms of, slightly off the case, but if you're giving somebody really bad news, why not have someone who's doing really well in that as a reference point for them straight away? In Japan, if someone's diagnosed with dementia, in the next room is someone who's living with hope and well with dementia to support that shell-shocked and terrible family. That's not expensive. That's just caring. That's just giving hope. That's just stopping the suicide rate and the despair and the hopelessness. In terms of other aspects as well, increase the referral to psychologists. I'm glad mental health is now front and central, but help to use what facilities are there as such for inclusion. I mean, even something as simple in one of the Southern Cross homes in Adelaide was they got in the exercise therapists. They reduced their falls like something like 73%. They just got people out and active and encouraged. Physios were way too expensive, but in terms of but also we need to stop the hype of that. So much of the so many preservatives are in our foods, and the sugar and the other things that are called so-called healthy, and they're bloody not. They're crap, carbonated, reconstituted, artificial and processed. So if great-grandma didn't recognise it, it's not food.
Right, okay. And you didn't eat it? No.
Well, no. Well, I mean, you didn't, because it was, well, margarine was ugly, and it was 1952 that the yellow was allowed to be put in it to be processed. Even the cockroaches won't eat it.
Oh dear, Val. Oh dear. Okay. So, Dimity, can you describe some of the options available to GPs that you can set up for chronic care support for older people? And are these options widely used and effective? And can you think of anything else that could be done to bolster the whole support health service in the community?
Yes, so the one that we all tend to use is the GP management plan and team care arrangements, which is a government-funded option where we make a list of the person's issues, and ideally I teach my medical students to actually negotiate with the patient what their goals of care are, and maybe come back and renegotiate next time, in 3 or 6 months. I don't know that that's commonly taught, but that's certainly the way we do it.
And what about introducing a more multidisciplinary network connection?
Well, so those goals of care, we do diet and exercise, the ones the students do. So they may include a dietitian and an exercise physiologist as part of that. But depending on the patient, whether the patient can afford it, under a care plan, you get 5 sessions a year across the whole gamut. And often there are more urgent things like podiatry or something that needs to be paid for. So it's tricky, but I would like to say there's something that we don't use enough, I believe, and that is case conferencing. And we can do that on the phone. And I think there is nothing like a bit of a verbal conversation with the patient and the primary care team. So that would include my practice nurse, who's wonderful and has a whole different perspective from talking to the patient, because they will tell her things that they wouldn't tell me. But it could include the dietitian or the physio or the podiatrist. And just to give you an example, I had one of my patients walking down the corridor using her walker, and she said since she'd had her hip replacement, she felt one leg was shorter than the other. And we walked past the podiatrist's office and her door was open. And I said to the podiatrist, could you measure her leg length maybe, and we could just see? And the podiatrist said, hang on a bit, just walk a bit further. And she walked a bit further, and the podiatrist said, I don't think that's that. I think she's got muscle tightness and it's pulling the leg, and it's a physio problem. Go to the physio who was down the other end of the corridor and get that reviewed. Then I was able to use the management plan to get that reviewed by the physio, and it was a muscle problem. It needed some physiotherapy to try and that made her more stable on her feet and less like.
And the patient benefits.
And I had no idea. I needed that input from.
Yeah.
So that's what we need.
Do you see any role for nurse practitioners in the primary care sector for older people?
I've done a couple of projects with nurse practitioners, especially around Alzheimer's disease, dementia. So we had a project that ran for 3 years, where the NP went out to visit people in their homes and assess them for cognitive problems and what services they might. And we thought that the GPs might not like it. You know, there's sometimes a bit of turf war, but we got so many referrals after the first couple. They kept coming after the project had finished. Nurse was long gone. It was such a pity. And then the nurse practitioner and I would go back and chat to the GPs in the case conference and the GP practice nurse about her findings. And the nurse practitioner knew the referral system in that area, up around Newcastle, on the outskirts of Newcastle, where there weren't enough aged care services. And it was fantastic. I'd thoroughly recommend that. But the thing is that it costs money, and the Medicare rebate for the actual NP to do that sort of thing isn't sufficient to cover her.
So there needs to be a review of the whole funding system around nurse practitioners to stop all this stuff. Yeah. Okay. Last question, Vazi. How important is primary care in the whole array? And do you have any future vision of what could be done in the primary care sector to help older people aging normally, and also those who are not doing that?
Primary care in the broader sense is the key, right? Not just, medical, obviously, but allied health. And, I think Dimity's covered a lot of that. It's people having more access to it's the key.
Okay. Well, thank you very much for being so candid and open and generous with your information. And I will now hand over to Natalie and Arikiki to bring forward any questions that came up on the chat board. So if you can identify if any of the speakers have been identified in the question, otherwise we'll make it an open question.
Thanks, Tracy. We'd just like to say thank you to everyone who's engaged in the chat box on the side. The discussion's been really interesting, and Aki and I have had a lot of trouble keeping up. So thank you, everyone. Early in the webinar, there was a lot of discussion around the challenges that older people from culturally and linguistically diverse communities face when interacting with the medical system. So Vazi and Dimity, how can the medical system be more culturally respectful and inclusive for older people from culturally and linguistically diverse communities and their families as well?
Okay, who would like to have that one?
I'm happy for Vazi to answer.
Okay, Dimity.
All right. Well, wonderfully, there are a lot of medical graduates from diverse communities and working in primary care as well. And I think it's fantastic that many of them are linked in with their communities. So then there's a cultural understanding and so on. But it's not without its problems, because even within one language group, there can be different ethnicities and various tensions and so on. Some of our students are currently based in Singapore because they come back to Australia, and they're talking about their GP placements there and how the GP, might be able to speak Mandarin and maybe Tamil, but not Cantonese, and how they have to get there to come and help with some of those. And so they're also encountering those challenges, even when there's a lot of languages.
The only thing that I would offer to that, and thank you, but the only thing I would offer is don't make assumptions about culture just because somebody has some sort of ethnic background, because they may not actually be adhering to the cultural norms of the old country. And to assume that they would, or assume that they would speak the language simply because they are from that background and have been in Australia several generations, I think it could be very embarrassing and very discouraging for them. So make sure you know what you're dealing with. Communication's the key, I think. Okay, next question.
Yep. So the next question, we also had a discussion about end of life and how we can engage young people. So the question we have is for Val. How can we make end of life and advanced care directives start at a very young age? And
how can it be normalized in our society? Would you have any strategies?
I saw a comment, and I think it's brilliant. When you get your driver's license, why not have to do your end of life records, and it's put on my health record?
Because you're 18 years old and don't know much about life is actually the answer to that.
Yeah, and you think you're bulletproof, but unfortunately, I've worked in the acquired head injury units where you've got your 18-year-olds who wish they had some say in their future as well.
But that's
so
right.
if
Not
we normalized
beforehand.
if we normalized it, this is what's expected. This is what adults do. I would think that's got merit.
Okay. Thank you.
The problem with advanced care plan, not the problem, the truth about it is, I wrote a comment about this, as humans change our minds on big things and small things. It depends on your life experiences. It's so complicated, right? That it's hard to come up with black and white rules and statements about it. In the real world, it is very complicated, and you'll be amazed at how people would change their minds on things as big as this. And they have every right to. Humans, we do it all the time.
I take your point.
Well, perhaps as practitioners, we could actually ask people for a copy of their intentions, and we could actually bring up the topic for them rather than standardizing them having to complete this. We could actually make it a priority in our assessments, in our interviews of people, and just ask them whether they have done this or not. And that would create an awareness of it. Are you happy with that, Val? Val, we can't hear you.
Oh, sorry, I did the thumbs up. I'm so used to Zooms and thumbs up.
I couldn't hear your thumb.
Sorry. That's valid, but it needs to come out to front and central.
It does need to be emphasised in some way. Yes, I agree with that. Yeah. Natalie?
So our next question is around medical education. So Dimity and Vazi, do you think it should be compulsory for all medical students to have a unit of study which focuses on older people and ageism?
Actually, we did a survey of all the medical schools, and the majority of medical schools, people get exposure to, I guess, medicine in older people. They certainly all get communication, but specifically whether they get teaching on inherent biases and, frankly, ageism, I suspect they get it in a very general sense, right, about how your own biases might influence and how you need to be aware of that. So they get that I suspect they get that in a very generic sense, but I don't think they have a unit, they don't have a lecture on ageism. I certainly talk to them about it, but, they certainly get good exposure to looking at it. It's interesting, the medical students have pretty good insight about the fact that their core business for the majority of them is going to be looking after older people with lots of medical problems. I mean, it's pretty obvious to them that that's, for the majority, that's going to be the core part of their work. So I think they get that.
Okay, thank you. Now, I think we've got time for one more question.
Yep.
Equity?
Maybe just the one below.
Yep, okay. So this one we have for Dimity. Have you noticed any difference in how older people are experiencing ageism today in comparison to maybe 20 years ago?
Dimity, would you like to take that one?
I think that older people today are much less likely to accept ageism. So I think that 20 years ago, you kind of ruled yourself out after you were 70 or something. And you just kind of turned into an old person and just kind of expected to be told what to do. And there was a much more hierarchical relationship between, certainly with the GP and the patient 20 years ago. But these days,
I agree.
Are
yes.
feisty, and I love it. I love it that people come and tell me, that doctor, I'm never going back to that doctor. Just treated me like an old lady and they called me darling. I'm not going to be called darling. And I think, right, I'm not sending anyone over the age of 65 to that doctor, and I'll warn them about the day. So.
Yes, well, I agree with you. People are more feisty, but that's the people who are capable of that. There are a whole lot of other people who are just not up to that, whether through language differences or for health reasons, or they've just never had the opportunity to develop that kind of confidence. I think we've got to take a special care to make sure that we include people who are still affected by terrible ageism that prevents them from actually engaging with a lot of things. But look, thank you very much, everybody, for that. Just in a few words of summary to round it off, we're actually encouraging everyone, administrators, clinicians and support personnel, to educate themselves about ageism and the unfairness that it causes. And preserving the high standards in health and aged care may require a groundswell triggered by people with knowledge of what could be and what should be, and who are determined to ensure that empathy and competence remain standard practice within our essential health services. Now, our session today is part of a global groundswell against ageism to which we can all contribute. And if we continue the conversation in our own networks, we will actually make something worthwhile of this. We have the evidence, we have the passion, we have a future in mind that we all want to share, and all of us need to get behind the movement to ensure that it doesn't dwindle again. So thank you very much, and I'll hand you over to Yumi.
Right. So on behalf of Health Consumers New South Wales and the Older Women's Network, we'd like to thank you so much, Tracy, for the seminal role you've played in getting us to this point, and to Professor Dimity Pond and Professor Vasi Naganathan. We know you've taken time out from your busy schedule to be with us, and to Val for bringing your very important consumer health advocate's voice to add that richness to what can seemingly be abstract concepts to this. We'd like to thank all the agencies that shared the information about this webinar, and to thank all of you participants for coming and expressing your interest in what is an extremely important topic of improving healthcare outcomes for our older people. I'd just like to end with what Vasi said earlier on, and that is, you get what you pay for. And that people are concerned about raising taxes to pay for better health outcomes. Our solution to that, Vasi, is really simple. Get the people who can afford to pay a little more. Like in Australia, only 1 in 3 big corporations pay their fair share in taxes. So imagine how much more money we can have for healthcare if they all paid their fair share in taxes. And so thank you, everyone, for continuing to put our shoulder on this huge wheel of ageism. We've got to push it to the top of the cliff and over the top of the cliff. So we look forward to seeing you all in the near future in another event like this. And our next steps will be to develop training material on ageism in healthcare. And if any of you are sitting on a lovely pot of money and wondering what to do with it, please get in touch with us. All the best and have a lovely weekend. Thank you, everyone. Bye-bye.